to talk about cervical medullary syndrome, craniocervical instability, and the hereditary connective tissue disorders. And this paper has recently come online. I paid to have it available for everyone who needs it. I think it'll be in print in a few months, neurosurgical review. I have a few inventions pertaining to the craniocervical junction and a new invention for craniocervical stabilization. Now, my goals today are that you understand that lax ligaments result in instability and deformation of the central nervous system. I want you to understand the rationale for craniocervical fusion and the hypermobility spectrum disorders and the outcomes of those fusions. Now, we're very familiar with craniocervical laxity with lupus and rheumatoid arthritis, and a great deal of literature by Gold and Crockard, and especially Menezes. We're also familiar, per Dr. Menezes, with osteogenesis imperfecta, but there are 50 hereditary connective tissue disorders, emblematic of which is Ehlers-Danlos syndrome. Even though it was described 100 years ago, the spinal and neurological manifestations have only really recently become recognized, and I have a manuscript there for everyone to take with you. So within these disorders, there are a number of very famous people, and the one on the right is actually a patient of a friend of mine at Hopkins. So we're talking about Marfan with a tall, thin habitus, arachnoidactyly, dilation of the aorta, the pectus, and they have lens dislocations and retinal detachment, scoliosis, and of course the feared complication, aortic dissection. And closely related to Marfan-Louis-Dietz syndrome, similar to Marfan's, they get dissection of the ascending aorta. And if you look in the uvula, there's a small bifid uvula. They have strabismus, craniosynostosis as children, a tendency to arterial aneurysms of the chest and abdomen, and foreshortening of the fingers, what's called camptodactyly. And the Stickler syndrome with hearing loss, visual problems, and they have a very flattened nasal bridge, flattened cheekbones. And the Ehlers-Danlos syndrome, you have heard, I think we all received about 5 minutes of instruction on EDS in medical school. That's what I received. There are 13 types. The most feared type is the vascular type. Fortunately, it's less than 5%, probably closer to 1%. And they have a tendency to rupture of mid-sized arteries, rupture of hollow viscera, and a survival usually in the 40s. Fortunately, the hypermobile EDS is the most common type, and not surprisingly, it's characterized by hypermobility. The ability to bend fingers, thumbs, elbows, knees, and touch your toes without bending your knees. That's the Biden scale. Typically, they have skin fragility, poor wound healing, hyperextensible skin, easy bruising. They have premature degenerative disc disease, osteoarthritis, scoliosis is very common, dysautonomia, very common, and you can see this with the mydriasis, the hyperhidrosis, sweating. They typically have irritable bowel syndrome with colic as children and bloating as adults. Lower left, you see the temporomandibular joint, ubiquitous in this population, and the blue sclerae. Most have some degree of postural orthostatic tachycardia syndrome, which is an increase in the heart rate by 30 beats per minute upon standing, or conversely, neurally mediated hypotension, which is a sudden drop in blood pressure by 30 torr after a few minutes of standing. And to some extent, this is due to pooling of blood in the lower extremities and the hyperextensible blood vessels, and also due to dysautonomic function. Many of these patients have syncope or pre-syncope, and syncope and orthostatic intolerance has been reported as a comorbid condition with Chiari malformation. Van der Popp, one of the great geneticists for EDS, reports the deformation of the central nervous system because of the ligamentous laxity. Now, Doug, who had to leave for a meeting, has described ligaments as the major stabilizing structures between the cranium and the C1, C2. So it's not surprising that disorders that are primarily that are characterized by ligament weakness should present with craniocervical instability, atlantoaxial instability, and subaxial instability. So our research subjects were 20, 19 women, 1 male. This is not my preference. It's just that even though it's an autosomal dominant condition affecting men and women equally genetically, the men are protected by the musculature, thick ligaments, and probably the slightly larger brain. The average age was 25, 18 with cerebellar ectopia, all had the connective tissue disorders. This is a retrospective IRB study. The data was collected by a third person, a nurse that I hired, not in the office. She did a follow-up survey at 2 and 5 years. We had 100% follow-up, all 20 patients, and this was a consecutive series, no selection. I did the neurologic exam, the neuroradiologist read the metrics. Now, the indications for craniocervical surgery are the same as for any patient population. After non-operative treatment has been maximized, the patient understands that surgery is the last resort. These patients all had a severe headache or neck pain greater than 7. They were disabled by their symptoms. They had the cervical medullary syndrome, which I'll discuss soon, and they had neurologic deficits referable to the craniocervical junction, incongruent radiological findings. Now, obviously, the preoperative radiological evaluation has to include the Chiari malformation, and I'm beginning to think that the most important part of the Chiari is not the pressure on the brainstem as much as obstruction of CSF flow and the turbulence it creates, and that effect on not just the brainstem, but even other parts of the brain. Coming back to what Wuda was saying. And this CSF flow can be influenced by the position of the patient, by the retroflexed odontoid, and loss of craniocervical alignment. That's been shown by Damadian and also by Atul-Goel. And we've seen this in the animals where Dominic Moreno has shown compression of the brainstem and obstruction of the CSF flow. Now, when does hypermobility due to ligamentous laxity become pathological? On the left is rheumatoid arthritis, and the middle and right connective tissue disorders, EDS. And in a consensus statement, which we arrived at 6 years ago in San Francisco, we decided there were 3 metrics that could be used that might be helpful in addressing craniocervical instability and basal invagination. Now, flexion extension, CT, and MRI are recommended. They're not available to everyone. And so you can do a jury rig, putting a pillow under the head for a flexion and a pillow under the shoulders for an extension. Not as good as an upright, but it'll get you closer. Clival axial angle is the angle between the clivus and the posterior axial line. Greater than 150 degrees is normal. Less than 135 is potentially pathological. Now, Scoville, back in 1951, recognized that angulation of the brainstem in basal invagination causes the neurological instability. And Van Gilder said that a clival axial angle of less than 150 degrees was associated with neurological deficits. Menezes talked about the fulcrum effect of the odontoid on the brainstem and spinal cord causing the bulbar signs. And Millerat showed that 1/4 of his Chiari patients had a retroflexed odontoid. Now, Kubota in his series in 2004 showed that Chiari decompression failed to improve Syringomyelia if the clival axial angle was less than 127 degrees. Kim, Riekate, Klopfenstein, and Volker-Sontag reported on 11 patients published in 2004. And in these patients, they recognized a type of non-traditional basilar invagination that did not meet the traditional criteria where the odontoid exceeded Wackenheim's line or McRae's line, but nevertheless they considered it a type of basal invagination. And this is what I'm talking about. And you can see the ventral brainstem compression there. So during preoperatively extension, a dynamic MRI of the cervical spine, they found that the brainstem fell away from the anterior compressive structures. So their goal intraoperatively with traction and reduction and extension was to achieve a maximal reduction of the basal invagination through distraction and cervical extension, and they had excellent results with their patient. In 2010, we published a series of 7 patients looking at the mechanical deformation, more an engineering study, using a finite element analysis of the brainstem and spinal cord, and we wanted to see whether there's any correlation between the mathematically predicted stresses in the central nervous system and the clinical result of the fusion stabilization. We applied distraction, extension, and posterior translation to realign the craniocervical junction and straighten the craniocervical junction, eliminating the medullary kink. And based on the work of Brieg back in the 70s, who showed that with the kyphotic flexion deformity there were significant longitudinal stresses, and that something like a retroflexed odontoid could also apply an out-of-plane stress. The combination of the longitudinal tension and the out-of-plane compression caused a geometric increase in the stresses in the spinal cord, which is reflected in the von Mises measurement. So in this patient, you can see the ventral brainstem compression, and when we applied our finite element analysis, we found extremely high tensions, very high von Mises measurements, in the order of 40 to 50, where in the normal flexion is a tension of about 5. And postoperatively, after performing the reduction, stabilization, fusion, we achieved normal stresses in the brainstem. And when we looked at all 7 of these, there's a very close correlation with the Asia scores, sensory-motor scores, the Karnofsky performance scores, and the physical and mental component of the quality of life SF-36 scores. Now, there are many other authors who have seen the importance of the kyphotic clival axial angle, and in 2017 we published a rather extensive review of the clival axial angle with a cohort of 10 patients. Now, the Grab-Mapstone Oakes measurement is the perpendicular measurement from dura to a line drawn between the basion and posterior C2. In their study, published in 1999, they found a group of patients with this ventral brainstem compression that they, like Sontag, did not feel was expressed by normal measurements of basal invagination. So they had 38 pediatric patients with Chiari 1, none with the odontoid above McRae's line, so they did not meet the criteria for basal invagination. Nevertheless, they thought that 28% of these patients had ventral brainstem compression, and they used the PBC2 line that I just showed you to demonstrate that ventral brainstem compression. They found that PBC2 was very reproducible. It was statistically significantly different from normal controls. It was a direct measurement of encroachment by the odontoid into the foramen magnum and the spinal canal. And they felt that this encroachment, more than the Chiari from behind, resulted in the distortion of the brainstem. Furthermore, when they followed these patients over time, they found that this distortion, this increased measurement, was progressive. So in the discussion, they said some patients achieved no long-term benefit from a posterior decompression, or have delayed neurological worsening days or years after the posterior decompression, despite an initial good response to surgery. In their series, the majority of ventral brainstem compression was seemingly the result of a posteriorly oriented odontoid and not true basal invagination. So for patients with less than ideal immediate or long-term outcomes after posterior fossa decompression, they recommended they thought ventral cervical medullary compression should be considered as a cause of neurological deterioration, which is why Dr. Marino is now doing decompressions. Now the Harris measurement, Harris looked at 400 normal subjects, and the distance from the basion to the posterior axial line was always less than 12 millimeters. And the distance from the basion to the top of the midpoint of the odontoid was less than 12 millimeters. It was the rule of 12s. Now that's on a plain X-ray, which is a magnified picture. So on CT or MRI, we'd probably need to use the measurement 10 millimeters. So this patient has a long basion axial interval, and that is pathological. Now there's a second aspect here. Between flexion and extension, the basion should not move with respect to the odontoid more than 1 millimeter. This was established many years ago by Weasel Rothman, Verne, Fielding, and White and Punjabi in the 1980, 1990 said the basion should not move more than 1 or 2 millimeters between flexion and extension. And I've reported it a few times, and Menezes. So here's a case where on flexion, the Harris measurement is 12 millimeters, on extension it's 7. So there's 5 millimeters of translation, and that's pathological. Now, in this population, there's very often C1-2 instability as well. In fact, it can be quite common not rare in the EDS population. And it's due to weakness of the alar ligaments, not the transverse odontoid, such as rheumatoid arthritis, but the alar ligaments. So here's a C1-2 hyperangulation, and you can see that the facet joints on the left side of the picture there are almost subluxed, and that patient has a 45-degree angulation between C1 and C2. So we put the patients in the CT scanner, turn the head full right, CT them, turn it full left, CT them, and we come up with these axial measurements. So on the left, the C1 ring is rotated 85 degrees, C2 is rotated 40 degrees, the difference is 45. That exceeds the pathological threshold of 41. That represents a rotary subluxation. So for a occipital-cervical fusion, I'd like to see 2 or 3 of the following: deformity due to basal invagination, or a pathological grab oaks, or a kyphotic clival axial angle, or instability by the Harris measurement, an obstruction of CSF flow, and or atlantoaxial instability. Now, where loose ligaments are concerned, you have to use dynamic imaging to show the instability. On the left, that film looks not too abnormal. A lot of radiologists might read that as normal. But on the right, you see with flexion, now the odontoid transgresses Wackenheim's line. That's clearly basal invagination. You have to use dynamic imaging. Operative procedure, evoke potentials, a limited suboccipital decompression, about 5 millimeters wide, but not too high. Screw fixation by the Gold technique. We harvested ribs for these patients at T7. The usual cut time was about 3 hours, EBL less than 100 mils on almost all the patients. Now, the posterior fossa volume, we all know, is significantly decreased in patients with CM1, in most cases, compared to normal controls. And the retroflexed odontoid further limits this or decreases this volume. So it's been shown that extension of the craniocervical junction by open reduction can improve CSF flow. And I've read that into Gold's manuscripts and also with the work by Raymond Amadian in New York. So in reduction, we always perform a traction, posterior extension, posterior translation, and extension. And over the course of a number of iterations, we'll position it, lock it, look at the fluoro, take measurements, discuss it, and then do it again. And we're looking for a number of things. One, we want to get the clival axial angle usually around 150 degrees. Secondly, we want to get the mandible at least 10 to 20 millimeters from the anterior aspect of C2 as seen on X-ray. If it's too extended, they'll have trouble swallowing. If the patient's too flexed, they'll have trouble swallowing. And third, we want to get the gaze angle right. And so we call that the orbital axial angle through the midpoint of the orbit, underneath the pituitary fossa, and a line intersecting with the line along the axis. It's the orbital axial, and that should be about 100 degrees. So that makes sure the gaze is in the right position. Now, here's the stabilization, and fused in this group we used the ribs, which did a fabulous job, except it caused a lot of rib pain. Results. So these patients had headaches, dizziness, arm weakness, neck pain, imbalance, memory problems, gait, arm numbness, Raynaud phenomenon, leg numbness, visual problems, leg weakness, vertigo, hearing, speech, micturition. This is the cervical medullary syndrome. And they have so many symptoms that many people just send them away, too many complaints. It's a post-operative wound. What did the patients think? And looking back, I would still choose to have the craniovertebral fusion surgery. Everyone agreed with various degrees of enthusiasm. I would feel comfortable recommending it to a family member. 19 out of 20 said yes. My quality of life was improved by having the surgery. All of them agreed that the quality of life was improved. The surgery improved my symptoms and decreased my limitations. 2 patients did not agree. They had so many medical issues due to the comorbid conditions of EDS that they were still very limited. The fusion rate using these autologous rib grafts was 100%. The symptoms that improved: vertigo, tremors, fainting, headaches, balance, speech, numbness, neck pain, dizziness, leg weakness, walking, numbness, swallowing, hearing, upper extremity weakness, so on. The average headache went from an 8 down to a 4. The headache's not gone. Now it's livable. There are many causes of headache in this population of patients. Same with the neck pain, about an 8 to a 4. Frequency of dizziness, much improved. Same with vertigo, walking, balance, and all of these were statistically significant. Memory was not significantly improved, and I think that's because of things like mast cell activation syndrome and POTS and so on. Now, I want you to carefully look at every single measurement here, or we can just skip to the summary. Of those people who had weakness in the arms and legs, almost all of them were better. Heel-to-toe walking sensation, Romberg sign improved. Now, 5 to 10% were worse over the 2 and 5 year period due to many other issues. The Konofsky Performance Scale looks at how they, well, I think you're all familiar with it. 100 is everyone in this room, no problems at all. 0 is dead. You need to be at 70 or 80 before you can think about doing any work. So at the 2-year period, improvement in Konofsky was statistically significant and remained significantly improved over the 5-year follow-up period, with the majority of subjects either returning to employment, school, or taking care of family at home. And the Konofsky scale before surgery in red averaged around 55. After surgery at 2 and 5 years, the average was about 78. It was significant at 0.001. So what were they doing? Patient 1 started out at Konofsky of 50. At 5 years is in school doing research. Patient 2 online school part-time. Next school waitressing. Next patient not in school, fully disabled, bedbound, part-time job, disabled, full-time job, full-time student, working part-time, student, disabled, working from home. You get the picture. A lot of these patients were able to return to some useful kind of work, and the reasons for no improvement in work or school status, 100% of these patients mentioned medical problems related to comorbid conditions, musculoskeletal pain, fatigue, dysautonomia, endometriosis, dystonia, intracranial pressure symptoms, joint dislocations, vascular issues, adrenal insufficiency, one had a pituitary adenoma, a recent motor vehicle accident, and other surgeries. So of these patients, 25% had had a Chiari decompression before surgery. Several had had tethered cord release, lumbar shunts. But after surgery, a number of them went on to have more surgeries of the cervical spine and thoracic spine, tethered cord, shunts, and I'll get into that again in a minute. Complications. The ribs worked great for fusion, but 15 out of 20 of them had persistent pain that was greater than a 3/10. So we don't use the rib grafts anymore. By 5 years, the pain was down to just 2 patients were still having pain. 2 patients had a superficial wound infection. 8 had pain over the instrumentation 1 to 4 years after the surgery. So that with this instrumentation we were using that had some high-profile screws, we had to remove it 1 to 4 years later. So we stopped using that instrumentation. One required blood transfusion. But there are no vascular injuries, transverse sinus injuries. There's no extension of fusion into the spinal canal, no instrumentation failure, or malposition of hardware. The claviaxial measurements went from an average of about 130 to 145. All of the other measurements improved over time. So how reliable are these radiological metrics in determining whether a patient needs a craniospinal fusion? So here's a patient who's got a Chiari, he's got a claviaxial angle. It looks like she has obstruction of CSF fluid. Radiologically, this patient looks like they really need surgery, but her pain was quite manageable. She was still working. I've been following her for 3 years. She does not need surgery, at least presently. So the radiological metrics are helpful, but they are only guidelines. They're not indications for surgery. Does the craniocervical fusion precipitate more surgery? Is there adjacent segment degeneration? So there were no surgeries at the C2-3 segment in the first 2 years, but over the next 5 years, several of the patients came back for C2 to T1 fusion, and many of them also needed cervical discectomies in the cervical spine. So most of these EDS patients present with diffuse cervical degenerative disease throughout the cervical spine. And here's a list of the subsequent surgeries: tethered cord release, LP shunt, hardware removal, and a number had anterior cervical discectomies at lower levels. Does the fusion cause disabling loss of range of motion? Theoretically, it should cut range of motion by half, but you wouldn't know it looking at these patients. They're so hypermobile. Not a single patient has ever complained of loss of range of motion of these patients with hypermobility. Other causes of headache have to be looked at. This girl on the left had terrible headache. We couldn't work out what it was. I sent her out of the hospital for a flexion extension MRI, and you can see that she was compressing the spinal cord, and she just needed an ACD at that level. Occipital neuralgia is not uncommon. Mast cell activation syndrome is very common, and we were just talking that mast cell may actually be involved in many of the dural tissue, connective tissues, and the craniocervical ligaments, and the inflammation thereof may be causing a lot of the pain, and some of the pain that you see as well. I had one patient who had a migraine headaches, very common in EDS, 3 times higher, and we did a transesophageal echocardiogram and found a patent foramen valley. This is the bubble technique showing the bubbles crossing, and we're able to treat that and stop the headaches. Very briefly, what is the pathophysiology of brainstem deformity? Well, Briggs showed back in the early 70s that if you press on the central nervous system, it causes longitudinal tension. And in the early 90s, I did a study on 10 patients. There were specimens of the brainstem and spinal cord, patients who had died from basal invagination, expected to find ischemic changes. Instead, we found these silver staining cells and opined that these were the result of a stretch mechanism. And we also saw this degeneration of the cuneate fasciculi and the axon chromatolysis. So shortly after, Pavlashok Maxwell Jafari showed that stretching neurons resulted in loss of the neurofilaments, collapse of the neurotubules. This leads to loss of the axon transportation and the formation of axon retraction balls, which in the brain are known as strict nodules. So this is what we saw. And in animal studies, Sadman showed that if you stretch the optic nerve just 20% of its length, i.e. a strain of 0.2, you get these axon retraction balls. And then some of them go on to degenerate. Wolf showed that if you stretch neurons, there is a deformation of the sodium mechanoreceptors, an influx of sodium, loss of or depolarization of the voltage-gated calcium channels, and a rapid influx of calcium into the neuron with the deleterious changes that affect that. And they weren't present in the controls. Rundin showed that there's an epigenetic phenomenon associated with stretching the neuron. There's upregulation of N-methyl-D-aspartate, mitochondrial dysfunction, and even apoptosis. And Shai showed that there's a decreased compound action potential with stretching the nerves, and this decrease is exacerbated by the rapidity with which the stretching is applied. We discussed all of these concepts, stretch-associated injury and the cervical spondylotic myelopathy, in a review article for the Journal of Neurosurgery published in 2005. That was Ed Benzel and myself. Now, there's controversy of these EDS patients because even though EDS was discovered a century ago, the recognition of spinal and neurological problems is relatively recent. And it's an invisible disorder because these patients look young, they have great skin, they tend to be attractive, bright, have a quick smile, high adrenaline levels, so when they see the doctor in the office, they're very high adrenaline, and they present well, but it belies their underlying disability and pain. They have a legion of disparate symptoms, so that most providers immediately back off and think that there's something wrong mentally with the patient. But the indications for craniocervical fusion should be no different than for the standard population, with the one caveat that you have to do flexion extension dynamic imaging to show the ligamentous injury. Economic considerations. These patients often have been to 50 different specialists before they get to someone who knows what's going on. And they've been to the ER many times and long hospitalizations. So there's a significant economic impact, a detrimental impact on the economy, even though it's less than 1% of the population. So earlier recognition and treatment can steer these people away from surgery and keep them as good tax-paying citizens. Limitations of the study, it's retrospective. All of these patients had comorbid conditions complicating the results. These patients, 12 of them needed other surgeries, and there was no control for placebo effect, which could be significant. Conclusions. Earlier studies have suggested that mechanical deformative stress in the brainstem and upper spinal cord arises from Chiari, obstruction of CSF flow, kyphotic clavilaxial angle, ventral brainstem deformity, craniocervical instability, and these stresses result in many neurological findings. Reducing the mechanical deformative stress appears to, or is associated with reduction in these findings. Dynamic imaging is necessary to demonstrate the mechanical deformation of the central nervous system. I'd like to acknowledge my co-workers and thank you for your attention.